Hello everybody, I'm Vittorio. I'm the Chief of Anesthesia of the Cardiovascular Thoracic Department of the University Hospital in Catane. We will perform an operation of thoracic surgery. The patient is a 64 years old man. He had a brain trauma some years ago during a working day, and he has got an empemia. Pleuric empemia, so we'll have probably a drainage and decortication of the pleura. We put the sensor for entropy in his front. And we put the sensor for NMT. And the pulse oximetry that works as surgical plethysmographic index. You can see from the monitor there was a decrease in the value of response entropy and state entropy. This is due to the fact that we did some sedation because the patient was very anxious before the induction of anesthesia. And we did just a little quantity of fentanyl. This is the reason why he's on 16 on surgical plethysmographic index. He's not feeling any pain at the moment. We have a baseline of 18. Now I'm going to administer rocuronium. As you can see, the response entropy and state entropy are going down, as you can see from the line. And we are going to measure the train of 4. Now we have 73% of ratio, top ratio. Now we are going to intubate the patient. And as you can see, the patient is not feeling any pain. The patient is with response entropy and state entropy quite low. And the patient is completely under neuromuscular blocking agent. We just finished to control our airway. We removed the T-tube, and now we put the bronchial block, and now we are just on one lung ventilation. We stopped the infusion of propofol and we are on desflurane, 6% desflurane. As you can see, the patient has got a normal entropy under 60, and the patient is not feeling any pain at the moment, 29, 28 with the surgical plethysmographic index. We are going to now perform an S block, a rectal spinal block. This helped us to control the pain during the operation. You can see just a little increase in the surgical plethysmographic index because we are going to perform the block. That's obviously natural. After we did the block, we had a value of a surgical plethysmographic of about 30, and because the patient was completely without any pain, the block is going to work. And now we have got the increase in surgical plethysmographic index because the thoracic surgeons are going to remove the drainage that the patient has positioned some days ago. This is the reason why we have an increase from the baseline of our surgical plethysmographic index. As you can see from the trend, here there's been an increasing of this surgical plethysmographic index, but as you can see, the cardiac heart rate does improve. This is the reason why we can consider as a good indicator for how much pain is feeling the patients. The surgeons had made the skin incision, and we are in a good control with the sedation. Just a little low value, but it's normal. And our rectal spinal block is working perfectly. As you can see, surgical plethysmographic index is 38 at the moment, in the range. And the patient is under deep neuromuscular blockade. And we have no infusion of opioids at the moment. We have also only desflurane infusion. And so everything is, all the pain is controlled by our block. This is very important because we are not so sure if the block is working. Surgical plethysmographic index is telling us that everything is fine. We don't need to add any other drugs like opioids at this moment. The pain of the patient is completely controlled by our block. It's very important for us to have the value of surgical plethysmographic index in this phase, because what anesthesiologists are used to do is to do an infusion of propofol or desflurane and opioids like remifentanil. But if you did a block and you are sure that the block is working perfectly, you don't need nothing completely. You need only to maintain the plane of anesthesia with gas, as we are doing at the moment, because we are sure that the patient is without any pain. So we need nothing. This is the reason why using this system, this indicator, surgical plethysmographic index, help the anesthesiologist to do not overuse opioids or other sedatives or other anesthetic agents during the maintenance of the anesthesia. We have had a big instability with the value of entropy during this phase of the anesthesia. And we could realize that probably the patient was not so sensible to the use of halogenated gas. And so we decided to start an infusion of propofol. We stopped completely the desflurane, and now we are going to use only propofol. Because as you can see, we have much more stability of the value of the entropy. And this shows us how much is important to monitor this parameter, because we can choose. We are able to avoid any overuse of the drug, but we are also able to choose the right agent for each patient. This permits us to have a tailored anesthesia. What we could learn with the use of adequacy of anesthesia, and what we could learn from the interpretation of these parameters, is that every patient has got a different response to each drug we are going to administer to him. And this is very clear from neuromuscular blockade at the moment, because as you can see, we are in a deep neuromuscular block, and we did only the bolus at the beginning of the operation when we intubate the patients. It was about 1.5 hours ago, and as anesthesiologists we are used to use neuromuscular blockade agent on the basis of the time, but it's exposed us to the risk of an overuse of this drug. The operation is just finished. Move the patients on the horizontal position. It was on the right side till now. And now we stopped the infusion of the propofol. And we are going to have to administer Bridion Sugammadex to the patient. We have three top counter, and this is the reason why we'll administer 2 micrograms per kilos of Bridion Sugammadex to the patients. Now we will wait for full recovery from the neuromuscular blockade, and as you can see, entropy is going to increase because we stopped the infusion of propofol. Now we have a complete recovery from neuromuscular blocking agent. We have top ratio of 93. We could extubate the patients, but we are waiting for entropy, for theta entropy to become much more closer to response entropy. The patient is still sleeping, and so we must wait probably some minutes still. We extubate the patient because as you remember, the patient was on a T-tube. So now we are going to put a tracheal cannula instead of the T-tube he had before the operation. Small difference between response entropy and theta entropy. The patient is awake, and we finish the operation.